My French is really awful, and you don't want to hear it. I will try and speak fairly slowly. Zach, if I'm going too fast, slow me down.
Okay.
If you don't slow me down, the rest of the audience will go.
Okay.
Okay. So it's a great pleasure for me to be here today. I'll also smile. If you're smiling, I know I'm going at a reasonable speed. Yesterday was a very sad day for me personally. It's the day that our Prime Minister signed Article 50, taking the process of the UK out of the European community. Now, you probably know that half of the country said yes and half the country said no, bar a little bit in the middle. And so obviously half the country is not happy and half the country is. This is politics. The Royal College of GPs, of which I'm the treasurer, is not strictly political. So we don't have a stance on this, other than to say that internationally we always want to work with you, we always want to work with Europe and the world, because we have one aim, which is to raise the quality of primary care for patients. And that's our aim effort. Can I ask you, where are most people from? Are you from France? How many people from France? That's most people. Okay. And one person from not France. Okay. It's from Israel, so you're very welcome. And can you tell me what part of your training, how many qualified GPs are here? So about half, and how many are in training to be a GP? Sonia, all the way from Reading, England. Your English is very good. Okay, hi, come on in, welcome. I'm just talking introductory comments. So, the Royal College of GPs, the thing to take home about the Royal College of GPs is that over 60 years ago, when the college was formed, there was no departments of general practice in universities. There was no research, virtually, in general practice in the UK. There was no training in general practice in the UK. And it was these very simple things that the college asked for. No, didn't ask for, demanded. They said, if you want good quality general practice, you have to have these things. Research, training, teaching in undergraduate for GPs. So we demanded those things. And we were one of the first countries in the world to introduce obligatory training in general practice because of that. And for a little while, I think Britain had some of the best general practice in the world. Just a little while. It's probably around the time I was born. Okay? Which is longer ago than you think. 67. So, and that's what drives the college. The college is all about actually improving care. And the college does the exam for all our GPs have to pass our exam, the statutory exam in the UK. Our members don't have to join them. So these are all volunteers, 50,000 volunteers, and they all pay me, I'm the treasurer, £500, which is much the same in euros now. Currency isn't worth very much. So we have 50,000 people all spending that amount of money to our college. And the college employs around 300 employees. We have 300 staff. I have a big staff to run with a very active political team, a very active media team. So if we have a campaign for something, if we ask for something, we've got a lot of staff behind us that make it happen. And I'm going to tell you what we make happen, because it's important. I'm also a GP in South London. I'll be going back there tomorrow. I'll be seeing patients all day. I spend about 30 hours a week in practice. Okay, so the background to this campaign, and I'm going to start asking you some questions in a second. So, okay. The background to this campaign was the fact that in the UK, 90% of all the interactions in the health service go on in general practice. 90%, 9 out of 10 interactions. Yet, we only receive 8.39% of the budget. So 90% of the consultations, 8.39% of the budget. Now, I'm the treasurer. Money matters. Numbers matter. Yeah? How can that be right? Yeah? Do you know how much or percent of your budget in Israel goes on primary care? Any idea?
About the same.
About the same, okay. Okay.
The same.
And in France, any idea?
Maybe the same.
John, yeah?
I don't know, I haven't.
Okay, I think it's much less.
Yes, probably.
I think it's more like
4 or 5%.
4 or 5%.
Yeah, 4 or 5.
Yeah, yeah,
Not easy to
Yeah.
calculate.
yeah, okay. So how are you feeling? Yeah, you feel good still? Okay. I was pretty miserable about this. Okay, so we don't think this is fair. Now the thing is that it hasn't always been like that. Okay, so if you went round and asked GPs in Britain, was there a time when it felt like we had a fair share? Was there a time when we seemed to have enough resources to do the job that we wanted to do? They would have said, yeah, it was about 10 years ago. Okay, roughly 10 years ago. Okay. And if you look at the funding figures, 10 years ago, we had 11% of the budget. Not 8.45, but 11%. Okay? And so we plucked this out of the air and thought, 11%, that sounds about right. We could do the job, 11%. Big difference between 11% and 8.45. And what's actually happened in the health service is that we're spending more and more on hospitals, which are getting more and more expensive, and less on primary care. And if you look at this, so the budget is going up. In fact, the NHS budget over 10 years went up by 18%, which is a big rise. Bearing in mind we're broke, or even more broke now, but anyway, we won't dwell on that. So the rest of the health service has gone up by 18%. And actually, the budget for general practice has gone down by 8%. So we've gone down, the rest has gone up. And yet we do 90% of everything that happens. Can that be right? The number of specialists has almost doubled in a similar period. In the last 10, 15 years, the number of specialists in hospitals has almost doubled. The number of patients has gone up. The age has gone up. The complexity has gone up. I'm working much harder. Okay? And we know that I'm working much harder because we register all the details. It's all computerized. We know exactly how many patients we see every day. It's all on the computer. And we know that we're seeing, over the last 5 years, I'm seeing 15% more patients, literally. I mean, headcount of patients coming through my door has gone up by 15%. In all other parts of the system, it's going down. Okay? So specialists in hospitals are actually seeing less patients. Okay? And they're probably doing more meetings, they're doing more CPD, they're spending more time with the patients that they see. Fine, that's all great. But we're actually seeing more patients. 15% when you're seeing around 1 million patients a day in general practice is a lot of patients. An extra 150,000 patients seen per day. That's huge. Okay, come on in, come on in. I haven't hit the punchline yet. So we're working much harder. And actually think about that. So I normally work about 10 and a half hour day. An extra 15% on that day means I'm working more like a 12 and a half hour day. And that's what I do. So on Monday I started before 8 o'clock in the morning. I didn't leave my practice until about 9 o'clock in the evening. Okay, pretty hard work. Lucky I love it. And this shows the numbers of GPs. And you can actually see that the number of full-time equivalents, not the head count, so the blue numbers are the head count, But the number of full-time equivalents in general practice is actually going down. So we're doing 15% more work, and the number is actually going down. How can this be right? It's crazy, isn't it? We think it's crazy. Okay, so basically what was happening was that we're working harder and harder, and actually if this carries on, it will be unsafe. I can work 12, 13 hour a day, but I can't work 14, 15. Not even me. And I'm really energetic. I love being a doctor. I love being a GP. There's no other job I'd rather be. But that would do me. That would be too much. Okay. So we thought we thought that the college thought quality of care, safety, is being threatened. I remember what I started with. I said it back 60 odd years ago when the college started. We asked for basic things: training, research, teaching in undergraduate. Very simple things. And we got them. Okay. So we decided we would have a campaign to ask for very simple things. This is important. So our asks was that we were to get 11% of the budget. Whatever the budget was for the health service, we should always get 11%. Not 8 point something or another, not 4%, not 5%. You definitely don't want 5%. 5% is really terrible. And the reason we want more resources is not for us to be paid more. This is nothing to do with my pay. In actual fact, I think I'm paid quite well. Not for video, no, it's already video. Okay, this is nothing to do with money. So this has nothing to do with our income. This is to do with resources. We want more time to spend with patients. How long is your consultations with your patients? How long do you spend? 20 minutes. 20 minutes! Okay. I'm holding on to the... average consultation time in the UK is between 10 and 12 minutes. Okay. You got 20 minutes. Is 20 minutes long enough? Yes. Thank you. Is 10, 15, 12 minutes for me long enough? No. Okay. And we do lots of things to try and make it longer. So we do, in my practice, we do this thing where a patient calls in, and instead of the administrator making an appointment, every single person that phones in, I ring them back. So that the GP speaks to every patient who wants to see a doctor. 40%, 4 out of 10 patients I deal with on the phone, there and there, finished. Phone call, done. I can email a prescription to a chemist or a pharmacy near to where they live. I can give them advice. Lots of people just have colds. I don't want to see colds. Do you want to see colds? Can you see colds? Lots of people with colds? I don't want to see them. There's nothing I can do for them. Yeah? And actually bringing them in encourages them to think there is something I can do. So come and see me because I've probably got something for you. I don't. Just a bit of love and care and, that kind of thing. So 40% of patients I don't need to see. The other 6 out of 10, I can help the patient decide how quickly they need to be seen. So someone coming for an annual check for their blood pressure once a year, it really doesn't matter when. It could be next week, it could be 6 weeks, it could be 4 weeks. But I can make a convenient appointment for them. But I can also say, you need your annual blood tests too. Why don't you do them first? So I'll book you for your blood test, and then I'll see you with the results, and I'll check your blood pressure. Bingo. All done. One go. So good planned care. On the other hand, another patient who may have something that they're not that worried about, I think I've got shingles, doctor. Can I come and see you next week? No. There's no point you seeing me next week. Either come and see me today, and I'll treat you, or not. They don't know that it matters seeing them quickly. So I can help the patients decide how quickly they need to come. The patient doesn't need to negotiate with an administrator. who have no medical training, they just talk to me. Okay, so, and we want to try and improve continuity of care as well. If we're overwhelmed with demand, we can't do continuity of care. We want to be able to reduce wasting times, and I want more time with my patients. Okay. Can I ask roughly, how does it work in France? Can you tell me how it works in France? Patient rings up, CDC,
yeah.
How does that work?
Most of the time it's the administrator answering.
Yeah.
Giving an appointment.
Yeah.
And
how long do people wait normally?
Depends. I'm working as a resident in 2 different offices. And one of them is like being food in the day.
Yeah.
Like it's free in the morning.
Yeah.
And the other one is like 2 or 3 days.
Okay, which is pretty fast.
Yeah.
It's pretty good. Okay.
When it's more, like if you say, let's see next week, next week, or yeah, it's not satisfying sometimes.
With my telephone, yeah.
It's actually it's not the same with practice.
Sure.
Because we are most of practitioners are private practitioners, so
Yeah.
they have to organize themselves. And in my practice, for instance, a patient call and they have a secretary.
Yeah, oui. Yeah.
And the secretary decides the patient if the appointment is
Urgent.
urgent. It is not emergency room, of course. Does it need emergency room? The secretary can ask the doctor, you want to talk to the patient, and maybe I should tell him or her to go to the hospital.
Yeah.
And the second possibility is to have an appointment today, and the other possibility is to have an appointment, and there the delay is 1 week or 2.
Okay. So that system that you have, that would be the common system in the UK. So most practices in the UK, maybe 80–85% would be that way. Our practice is unusual in that we do this telephone triage. I believe not far in the future we'll be doing Skype. We'll be doing teleconferencing. The patient will phone up, I'll have a video conference with them. This is possible privately already in the UK. I'm talking about the public sector. And remember, our patients in our system don't pay any money at the point of care. There's no money, there's no insurance number, there's no certificate, there's no cards. They just come and we see them. So there's no money, nothing. Very straightforward. And there are people who say, there are health tourists ruining our health service. Millions of pounds. The budget for our NHS in England is about 110 billion. If we lose a few million for health tourists, it really doesn't matter. And it would cost more money giving everyone a special card and a chip and extra administrators. It would cost more money just to do that than what you would say. But politically, might go down well. We think it's a stupid idea. What is it?
By the triage like telephone, would you cause some patient legal problem? There's something.
So the question is there some legal problem with medico-legal? I haven't seen them, I haven't touched them, I haven't looked at them. I think you're right. I think it's harder to do good telephone advice, but an awful lot of what we do over the telephone is pretty straightforward. And people need education on how to look after themselves. And yes, I guess you're always worried that someone with a cold has meningitis, for example. That's the one everyone worries about, meningitis. And it's true. You may, but the thing is, even if you see these people, you may also miss their meningitis. Yeah. And there's some good research around recognizing meningitis, and it's often nothing to do with signs in it. Most people know if you come out with a rash that looks like a bruise, that's bad. Yeah, and actually it's how you pick things up early on, and it's other clues, and it's actually other things that there was a research by Steve Granier from Cardiff who looked at, he interviewed a load of GPs and it was actually picking up the urgency in people's voice and other cues that made them, it was a gut instinct actually, and a lot of what we do is actually instinctive. There's something that makes us worried about this patient. Also knowing people, which is easier if you know people, that you get it right. Okay, so the basic thing that we asked for was 11. Yes, sir.
Excuse me, just a remark. I have the same organization as most of my colleagues, but about the cold, you talk about education, like about re-education sometimes of the patient.
Yes.
It can be really useful to see them the first or the 2 times to learn them.
Yes.
So
yes.
For me, it's really important.
Yes, absolutely. So we can educate people by the phone, and don't worry, they still come.
Yes, but I need to see them at the first time because by the phone it can't work.
Okay.
On my side, I need to see them
okay.
to transmit some sort of knowledge.
Yeah. So also, it varies on the individual profession.
Exactly.
So not every doctor is comfortable doing telephone triage, and for some of us, they just hate it. Okay. Yeah. And it could be.
To continue with these calls, do you have a special insurance in case you miss this meningitis?
Special insurance? No. Insurance is a good point, though. Insurance in the UK for a full-time GP. Oh, thank you. Insurance for a GP, it's actually the highest risk thing you can be, other than an obstetrician. And any idea how much it costs for a full-time GP in the UK to pay insurance? We'll talk euros. How many 100 or 1,000 euros? Any ideas? Do you know, Sonia? No, full-time yet?
2,000 something.
It's about 7,000 euros for a full-time GP per year to insurance. Okay, so it's all built in, so you don't pay extra for doing telephone work. You do pay extra for doing out-of-hours work. So if you do work when you're working at the weekend and you're looking after patients that aren't your patients, there's extra money to pay. And in fact, there are now allowances to try and encourage people to do the out-of-hours work because they wouldn't do it otherwise. They'd be paying so much more to do the work that no one wants to do anyway. Thank you.
In front.
Just to know, how much time do you pay every day for those calls? And is it like all the calls in a row, or do you interrupt yourself every time?
So how it works in my practice is that I spend the first hour and a half phoning people, and then I'll spend 2 hours seeing people. And because I know what they're coming with, it allows me time to look at their records. It allows me to give them a longer appointment if I know it's going to be complicated. And if I know it's just a rash, I can give them a shorter appointment. So it also allows me, I don't know if you know this term, heart sink patient. So a patient that makes your heart sink. Okay. It's probably international language. It's a bit of a derogative term that I probably shouldn't use. Oh, my camera is really good. So patients that might be harder, because I organise my own clinic, I wouldn't put 5 difficult patients one after the other. I would put one I like, one I might find harder, and I give them longer. So yesterday, for example, I had someone who had really complicated pain following cancer treatment, radiotherapy, chemotherapy, surgery, multiple surgeries, etc. I knew she was coming. I knew she had some complex pain syndrome. I knew she'd seen 5 different specialists. I had time beforehand. I spent 15 minutes beforehand reading all her care, putting it all on one piece of paper in a diagram. And when she came in, she knew straight away I knew all about her. And the consultation took 15 minutes. And she said she gained more in that 15 minutes than she had done by seeing any one of the other specialists, because I put it all together.
But it means that you know why they're coming.
Mm-hmm.
Every time.
Mm-hmm. Oh, people lie sometimes too. So they say, and then they come in and they've got something down there. That can happen. And also some people, the concept of using a ticket, so they come in and say, I've got something with my arm, but actually they're depressed or there's some other reason. Sometimes that happens too, and that's okay. It's okay. Someone else had another question? Yeah, pass that one.
I'm not sure we have time for this, but you're basically telling us a fairy tale where everything's possible, but do you feel like it could happen in France where we are paid on the numbers of encounters?
Yeah.
So if we don't see a patient with our phone, we are not paid. I know that in Canada, for example, patients pay for a phone call, for sending prescriptions to the pharmacy and so on, stuff like that. So I'm not sure that your organization may be transferred to ours.
Yeah. Okay. So I totally agree. It's always a fairy tale. Okay. And it was a fairy tale 66 years ago when we said, hey, if you want GPs, you need this, this, and this. If you want a health service that works and is sustainable, you sometimes have to make fundamental changes. And that can be and it's usually not so much about money, but about culture. So it's a culture of your patients, culture of your doctors, culture of the way that you do things. Same doctor, same office, same equipment, different way of doing things. For most of you guys, I'm 50 this year, so I have another 10, 15 years of work left. For me, it is inconceivable that we will be doing the job in exactly the same way now as you will do in 15 years' time. It cannot be. Who should be leading the change? Your politicians, your patients, or the profession? And I would say the change, any revolution, should come from both the patients and the profession, because they're the two stakeholders, not your politicians. What do they know about health? What do they know about health? Very little, generally. Okay. So if you work with your patients in a partnership, then that's where power comes. And every practice in England has what they call a patient group within the practice. And when we were considering this new way of working, we involved them very thoroughly in the process. And they advised us on how the administrators should sell it. They advised us on our letters. They advised us whether they thought it would even work. And with the patients together, you've got a chance. Sorry.
I think another power that will lead the change is technology.
Yes.
And usually in medicine, we are just lagging after. We are not enough. We are too conservative. Mm-hmm. But technology, and I see it is changes the behavior in health services very much. We have to use it and to plan it, what you said.
Absolutely. So other technological advances that we would use, and a good number of practices do this in Britain now, is that they have computer triage. And so patients will email via the web and work through a systematic questionnaire. What's wrong with you? How long has this lasted for? It's intelligent questions based on what you're writing. And that then gets emailed to us, so when I speak to you, sometimes the computer program can give the advice without the doctor even being involved. Could that be possible? You're not going to like that. If you didn't like the phone.
Actually, it's okay. This is clear enough for you.
Yeah.
Actually, I'm really sensitive to what you're saying, because I'm actually living the dream at the moment. I'm really focusing most of my time and energy on organization skills, which means that the stress is relieved from the new paradigm I put in my the method of organization. It's just a normal phone.
Yes,
so,
that's fine.
it could be email, but we can do that in France, even though it's consultation.
Your point about the fairy tale is that in the UK we are paid annually per patient. So we have a capitation of around 80-90 euros per patient per year. You come 10 times, you come 2 times. The same capitation. Okay? So it's in our interests to drive numbers down. For you, because you're paid per patient, to drive it up. Same in our hospitals in the UK. So if our hospitals A&E didn't see anyone, they would have no funding. So it's in their interest to encourage people in. But it's a stupid setup, and we're trying to move away from that. Okay, so fundamentally, we want to also make it based on a capitation for hospitals. So they have a set budget, and they have to work within that budget. They have to make it work for the demand that they have. And a big example in Manchester, one of our biggest cities, or it is our biggest city, up in London, that's how that's going to work. So you've got a set budget, make the best use of it. So instead of pulling people in who don't need to come in, look after the people who need the care the most. We have a precious resource, a precious amount of money. We need to use it very wisely, especially as a treasurer. Okay. So we got a petition signed by over 300,000 citizens. We had thousands of letters written all over the place. We had loads of meetings with ministers, politicians across 4 nations. So there's 4 nations in the UK: England, Scotland, Northern Ireland, and Wales. There was even a debate in our House of Commons to discuss the importance of investment in general practice. This is the lady in lilac was the chair of our college, Professor Maureen Baker. That's the chief executive, the former chief executive. The 2 people at the front, Harvey is our patient lead in our college at the time. Okay, so we have a patient group within the college that sits on all major Royal College of GP committees. Patients have a strong voice in the college, because at the end of the day, college is all about improving patient care. So it's very important. The lady on the right there is Patricia Wilkie. She's the president of the National Patients Association. Okay? So we had the Patients Association behind us, we had the patient lead within our college behind us, and that's the petition. 330,000 signatories, and that's number 10 Downing Street, where our Prime Minister lives. We've never had such a big campaign as this ever in the college. And for 3 years, it's pretty much all we ever spoke about. And we've got a team of 4 press officers, a team of probably about 10 or 12 policy workers with a director in charge. So we've got a team of about 15, 20 people working on this campaign. Our college is in the either newspapers, TV, in the national press every day. Okay? Pretty much every weekend I get a call to say, can you do an interview later on today on TV or whatever? And it's always about some health thing, so it might be about statins, cholesterol. Okay, great. And we'll say, yeah, we'll come and talk about statins and cholesterol. What we're really saying is, yeah, we'll come and talk about our campaign. Okay? So we'll say, we'll come along, they'll say, oh, tell us about, what do you think about these statins? But if only doctors, if only GPs had more time to spend with their patients to explain the importance of statins, and that's why we're asking for 11%, So pretty much every time we would be on the news or in the papers or anything, we would keep this campaign going. You can imagine how pleased our politicians were. The fact that pretty much every time we were on the media, that we would mention this brilliant inequity between how much work we do and how much of the budget that we receive. So after lots of media, lots of discussions at a very high level, we got this. This is called the General Practice Forward View. And this was a tripartite, three parties agreement. So it was the government, it was Health Education England, which is our education authority, and us, the college. Three people, all agreeing what we think to be the way forward. This was an absolute historic moment for us. That the college would be right at the centre of agreeing something. Bear in mind that the Royal College of GPs is not the union. We are not a trade union. We don't negotiate pay. Our sister organisation, the British Medical Association, is our union. And all GPs generally are members of that too. So I pay around €500 to the college. I also pay around €500 to the BMA. They're the people who negotiate our pay. This was not about pay. This was about resources. Okay? And this is what we won. 2.4 billion extra a year by 2020. Some people say to me, what am I getting for my €500 a year? I can point them to this. Okay? So if you guys could pay a membership fee, which I know you don't, because that your college is a college of organisations rather than a college of members. If I was to say to you, if you wanted really strong professional representation, and if you were to pay €500 a year, your envelope would go up from 4% to 8%. You would not get any extra money personally, but you would get that extra resource in your health centres, so extra nurses, psychologists, administrators, training. Would it be worth it? I'd say yes. I don't want to, I would love to earn more money, but that's not my primary goal. I want my job to work. I want young people who are joining my profession in the UK to think this is something you can actually do. It's sustainable. You don't have to work a 30-hour day. I want them to be able to think this is exciting. I love being a GP. I genuinely do really enjoy being a GP. But actually, if things got carried on getting worse, even I would be thinking, I can't do this anymore. And hand on heart, I would have difficulty saying to someone training, you know, this is a fantastic thing to get into. And I would say that now. I would say that you have got a brilliant career ahead of you. Genuinely. Because actually, the government is saying that they will guarantee that at least 10% of the NHS budget from 2020 forevermore, always a minimum 10%. So from 2020, we will always get a minimum of 10%. And actually, with other bits of money coming in, it will probably be more like 11%. A commitment to recruit 5,000 extra GPs in England. That's a huge amount of extra GPs. And I can tell you that the health secretary personally, is a chap called Jeremy Hunt, is personally very engaged with that. He literally holds the training organisations to account. He's been literally on the phone telling them, what are you doing about this? What's happening? Where are my extra GPs? Literally. A genuine personal commitment to that. Okay? And we know this because we hear this all the time. To say that he's screaming at people to get this delivered probably isn't an understatement. £500 million to help make the system more sustainable, £40 million for a resilience programme, and another 108 other measures. This was a massive breakthrough. Fairy tale. It is a fairy tale come true. If I'd have said 5 years ago that we would be guaranteed 10% of the Health Services Fund forever, and the Chancellor of the Exchequer, our Treasury Minister, would guarantee that. If I said to you we would get an extra 5,000 GPs, we would increase the number of training places and all those things, anyone with a reasonable head would laugh in your face. Yeah. But we got it. Mike.
All I see around me is the young faces of young GPs. Oh, yes, I'm with you. How do you feel about this, that none of our representatives are here to hear you today? Basically, we have a situation that is quite different in France. I know that it's recorded, but I don't care. We have two colleges, the teaching GPs and the College of Médecine Générale. I'm not sure, once again, that your fairy tale can translate to France. How do you feel, what do you think that it was important that in England, in UK, there was only one college that was in charge of this campaign?
Yeah,
that was important.
It's the topic of the workshop in a moment.
Yeah, so unless you're united and you are very professional, because in this day and age, you need to be Facebooking, tweeting, you need to be on the newspapers, you need to be on the TV, you need to be on the radio, you need to be there, and you need to be there every day. Twitter is, you know, if you're not on it today, you might as well not exist. Yeah. Yeah. I don't tweet particularly, but the college does. We have someone full time on it. We have someone just constantly doing this. Modern communications today, you have to be really professional. That takes resources, it takes planning, but it also needs professional engagement. So they can't be done by a load of professional media people on their own. It has to be us. It always has to be us at the front of the newspapers. The politicians and GPs are trusted, okay, 100%. Okay, and the only trouble is that the trust is 88% for GPs, only 12% for politicians. So politicians have very low trustworthy ratings. Generally speaking, certainly in the UK, GPs are lucky, but we are highly trusted. And politicians know that GPs are listened to. You are very powerful. We see 1 million people a day.
Emile Zahad, I'm a French GP. Yeah, it's almost a fairy tale about all your points, but I was wondering about the third point, commitment to recruit 5,000 more doctors. Are they coming from abroad, or do they intend to...
Okay. I'm going to show you my next slide, because I'm going to show you the things that we'd asked for and what we got. So we'd asked for 11%, we got 10. That wasn't bad. And I think with other investments, we probably will hit the 11. But the important thing is that it's pegged. It's set at 10%. So as the health budget goes up, we go up, always goes up. We'd also asked for £262 million to try and transform general practice. Remarkably, they gave us 500, which makes you think we should have asked for 8. But anyway. We actually asked for 8,000 more GPs, and the government offered 5,000 extra GPs, but 5,000 other staff working in general practice. The key thing here is mainly for us to train our own. Britain has in the past imported a lot of doctors, and we've been very dependent on doctors from around the world. Which doesn't make sense. Partly because we're a rich country, well, rich relatively, and we should be able to train our own. There are plans to open a further 3 medical schools in the UK. We've hugely increased the number of doctors that we are training, and this should be done mainly through self-sufficiency rather than importing doctors. The 5,000 other staff, and generally in our practices, we have a whole range of other staff. So in my practice, we have nurses, we have psychologists, we have counsellors, we have benefits advisors, we have midwives, we have community nurses, we have, who else do we have? Mustn't miss anybody out or get shot. That's a good start, sorry?
Dietitians.
Oh, we don't have dietitians. Now maybe we should. It's a big problem. So we have big teams. The new people, the new professionals that we are trying to recruit are pharmacists. So there's a plan to have a pharmacist attached to every practice, and that's why I forgot, because our practice has a pharmacist, has done for the last 2-3 years. There to help guide optimization, improvement of medicines management. And our pharmacist colleagues can help us hugely here and do a lot of the legwork, a lot of the hard work around medicines optimization. When I say optimization, I'm generally talking about money. Okay, so cost cutting to make it more efficient, because that's a big part of our budget. Indeed, yeah. Microphone.
You told us about healthcare professionals.
Agnès, take the microphone.
Agnès Pelletier, I'm GP from France. You told us about healthcare staff, but about administrative staff, how many people do you have per GP in your practices?
So probably roughly one whole-time equivalent administrator. So we have a team of receptionists, a team of back office administrators, managers, etc. But it's probably around one whole-time equivalent per doctor.
And do these people are part of the 5,000 other staff working, or it's other staff working, it's healthcare professionals?
Yeah, these are healthcare professionals. So the extra 5,000 are not administrators, and they are psychologists, mental health workers, pharmacists mainly. Those are the main groups. We struggle in the UK to train enough nurses as well. So there's a bit of a shortage of nurses. We've got hundreds of thousands of nurses. It's not enough. I don't know. Do you have a shortage of nurses in France? Yeah. What other colleagues would you have working in your practice? What other?
I'm sorry?
What other health professionals would you have working in your practice?
Once again, it's all private practitioners and staff. So I work in very professional medical home.
Okay, medical home. Yeah. Okay. So medical home is something to try and get into.
So we are 40 people, nearly 50 people, but we're not in the same location. We're not in the same house. We are in an area, and it's 30,000 people city. We're not the only medical home in this city, and we have nurses, dietitian, psychologist. We have an experiment about a community nurse. It's called infirmière azalée for. It's so yes. That kind of nurse isn't the mainstream kind of nurse. It's exceptional. In France, it's these people are rare. We don't have community nurses in our practices. It's maybe some hundreds in France are actually that kind of nurse, but it's very exceptional. I can't remember. We have physiotherapists and.
So it's very similar, actually. Is that the same for most people or not? Hands up or down, and I'll come to Israel. Sure, it's coming. Sorry.
I want to remark that I think this is one of the most important part of the whole program, the extra extra professionals.
Yes.
And countries like France which I understand really work in solitary clinics, should make this a big change. And maybe this is one of the reasons you succeeded, because you showed by this you were very serious and professional, not just more money. We are working to enforce the basic triangle of family medicine. As we profession. This is the nurse, the physician, and the social worker, or yeah. And we really understand now, because we also have very old people with many chronic diseases, that we have to add the dietitians. That's why I asked him. I think she is, or he is, the fourth professional in the basic team to treat the patients. And we very much encourage the clinics to work as group practices with all these professions in there or around there, and they make a real teamwork together. This is very, very strong, very important.
And you made a very important point there. So you mentioned three important people. You said the nurse, the doctor, social worker. Okay. Now, social care, healthcare and social care, there's a huge overlap there. When I was training to be a GP in 1996, we had a social worker in our practice, and I just assumed every practice in UK had a social worker. Her name was Linda. I still remember her now very well. And my trainer, who was a very wise person, like Jean-Pierre, called Penny Owen, she said to me, she said, Linda, our social worker, is as important as any other doctor in this practice. She has such a huge impact to our patients' care. She said, I cannot imagine being a GP without this social worker in our building. Cannot imagine it.
And if I can add a tip to that, we also had a group practice for 30 years, and we got the social worker from extra source, not from the health organization, but she worked with us, and we made staff meetings at least once a week, and she had a very important role in the staff meeting also. She was our social worker, the workers, not only for the patients. And so I think it's very important.
Yeah. So that's another point, is about meetings. So meetings sometimes feel like a curse, because you're spending time meeting each other rather than seeing patients or doing your paperwork or whatever. But actually having a weekly team meeting, again for me, is essential. Absolutely essential. So much so that I encourage my practice to meet every day. So my practice meets daily for 15 to 20 minutes every day. All the doctors come together and we discuss the most difficult patients. We discuss anything that we can't quite cure. And for me, that is one of the most important things that I can do as a senior GP in my practice, is to meet all my doctors together, and they've got an opportunity to say, I don't know what to do with this patient, they're like this, and this. And someone will say, oh, had you thought about endocarditis? Had you thought about this, that, or the other? And professionally, it means we all work together. We all look after each other. It's incredibly supportive. And being a GP can be very lonely. Risk-taking, which is going on next door, very hard to risk-take on your own. And actually, if you're risk-taking with someone and you've got the group behind you, who said about insurance? Insurance, that really helps you. You have more confidence that you're doing the right thing. And I think, again, some of this is culture rather than money or resources. It's the culture of working together. It's the culture of supporting each other. It's a culture of doing the best thing for our patients. So when we're meeting together in our group, we're actually always just thinking, well, what's best for that patient? I'm not really interested in anything else. Are we doing the right thing? How many people here meet daily? You meet daily? Fantastic. Anyone else? No. there's one thing that can change your professional life is closer working together.
I would like just like to have a moment to work on the workshop.
Okay.
Yes, go on.
Sure. The final thing I'd say as well is about relationships with other workers, such as the social workers and the nurses, etc. If we work closely with our colleagues, we value what they do. We also value and understand what they don't do or what they can't do. Often we sometimes have a fairy tale that send the social worker and they'll sort it out. Social worker problems, magic. They're the same as us, they're human beings with resources and all the rest of it. And actually if we know each other and respect each other, we can use the service much better. Similarly with our nurses, when we have a good relationship with our nurse, if they're worried about someone, we know we need to be worried. If they're not worried, then we're probably okay. So those relationships mean a big difference. If we have anonymous people that we work with, that doesn't work in healthcare.
Just a point on that, because in my practice, it's an old practice. It's an old practice, and I just have a secretary, which is fundamental to me. I speak with her daily, all the time, in the beginning of the day, and she's really useful to give me the temperature. And actually, it's a cleaning lady as well. And we don't speak about them, and they are also very important, especially at the time when there are lots of service of calling external secretary. It's something missing here as well.
So in the UK, we still have some practices that are single-handers, work on their own, but we often now associate them with bigger practices so that they come together for those meetings once a week. So although they work in little hubs, they come together and they get learning from the wider group, which is powerful. Jean-Pierre.
Paul, but I would like to have a small moment to work on the workshop before the end.
Okay. I haven't actually got that much more to tell you about this campaign. So basically the campaign, the GP Forward View has been running for a year, and it's been a bit slow. Okay. So some things are being delivered. So I think we certainly can feel that there are extra doctors being trained. But as a GP in my practice, I'm still working 13 hours. Okay, so I think we are very much on their back. We're very much pressurising them to now deliver all the things that they promised. Okay, should say, and this is a 4-country thing. So we've very much been pressurising them in Scotland as well, and Scotland have also announced extra investment, a little bit less investment in Wales, and Northern Ireland's in a bit of a pickle because their government is actually in an interim situation, and I don't think they actually have a government that can make decisions at the moment. So they're in a slightly difficult situation politically. That's the picture. So basically, I guess what I'm saying, our campaign was put patients first. Back general practice, so to really give patients, so most patients' interaction with the health service is us. 90% of all consultations is us. Okay. That's where they get most of their healthcare. If you invest in us, we will give our patients the time they need, we will be trained better, and we will be able to offer a better service that will take pressure off the rest of the health service. That's our dream. Thank you.
Thank you, Steve, because it was a delighted presentation, because it's the same when I hear BBC Radio 4. I don't understand. And sometimes if I hear something I don't understand. And it was very interesting. No, I would like that we divide into groups, 2 small groups. And I have only one question to ask to you. This one. The only question is what the college, the medicine general, can do to increase the part dedicated to primary care in the budget of the global budget of the social insurance. Because I remember Jean-Pascal, the College of Anesthesiologists is a federation of all organizations without individual members and fee members. You can divide in two groups, and we think about this after we made the proposal, and next year we will have more money for the family.
You have to dream.
I have a dream. In two parts, more or less, it was. We have not a lot of time to think about.
They want to just facilitate one group, not facilitate.
Take the chair. I will
The man in there's going to love this. We can talk about our college has no right to strike. We have no rights to our power is pretty soft power. We spent hours meeting the head of the health service, meeting civil servants at a very senior level, lots and lots of administrative managers. We spent hours with them. So much so, can you quote Simon Stevens, what he said about fees? So Simon Stevens is the head of the Okay, so what Simon Stevens said was that GPs have the most important role in modern UK. The most important role.
15 minutes. Who will make the reverse? You will. Thanks.
Perfect. Okay. So what should your college do?
Le collège de médecine générale discussions are made between unions. I think so.
Maybe there could be a good idea.
No.
Some program for the organization.
I speak French.
Maybe 3 days.
We have to speak English.
It's an English word.
As senior GP.
I think most of the discussions about money today are done by unions and government directly.
Yes, but unions and members.
Yeah.
If you have the basic knowledge and those skills,
But you don't have members of the place, so I think the place are
obviously,
as it was.
it really takes to work like that and really stress. I think is actually get my colleagues it's easy to work. Even as well, I do 10 hours a day,
Not only about the union.
and I still have more consultation. And I have one day waiting. And because I work,
What is your point?
I think the point of Julia is that the company is based on tax. We put attention first.
So
We don't discuss about Julia, we don't discuss about
put the patient first.
we just discuss about quality.
So it's true that if you have,
Yes,
we do
but
not have,
if we ask
to my knowledge,
directly,
the patient associations in France do not meet
but the
with
student government needs like
not on a regular basis, not on a regular or like an obvious, in an obvious way. And so it's true that I think that we can only, because GPs in France, I don't think we have the best representation. I think a lot of people think we just want to work 3 days a week, have a nice car.
I don't agree with you because the GPs are not considered to be very individually. Your patient think you are the best med in the world.
I agree.
So you have the best work you are, but they also think that other GPs may not be as good as you. So I think that you have more power. What do you think? If you tell your boss, do you want to join me? Come to talk with the say, please. And maybe one or two will come, and you have a lot of politic power.
Yes.
So that's some more everyday world talking about scientific research and patients. The thing is not like sense. Many medicines on the whole, first of all,
many hours, many patients
saying the same thing. Where
want to hear
money, where
from sanitation or
health, social care. They will listen to us.
At a very long time.
Since the beginning. Medicines they will sell and one time in a month, in 6 months in the media.
So you're saying
I think it's
as a more present in the media.
more visible to the public. Because have the power and they don't represent the GPs. It's kind of forced only 10% of the people.
This is not good.
In terms of knowing what the patients want, one thing we do in our surgery is we have a set of patients who are sort of put themselves forward saying we would like to put some time into improving our local GP surgery. We meet them regularly. They give us valuable information about what they actually want from the GP surgery, what they find is working, what isn't working. And that's useful on a local level to improve your own GP surgery, but also that information can then be taken higher to say, this is the information that we've actually got. It's not just me thinking that this is what my patients would like, this is what they're actually telling us. And we have them sort of a set number of patients throughout different ages and to try and balance that. I don't know if that's something that
this kind of
do it all or
needs, we have this kind of
try
Just talking about medicine in France and other capitalist societies. Because, for example, in Belgium, UK, in France, it's starting to commercialize some medical products, medical care, and so usually I find that in France, doctors, we don't hear much the voice of general practitioners.
I feel like going national. To national issue is just like you said.
It's just, I felt there's a difference in the culture.
I don't have any idea. Maybe using patient association
compared to other countries,
France is very
they're diverse.
They're diverse.
There's no national or
yes, they're absolutely
about the future.
There's no primary care association. And the other thing that basically I don't communicate, right?
It's not the first thing you talk about.
3 years.
If you like the first pay ahead, you can. We need money.
3-year project.
We need to say we need more representation, we need more practitioners.
But it sounds like anything you did would have to be a stepwise thing, which would last many years anyway. So perhaps if you started small, you could then extend that from one surgery to a region, and then take that forward and have a voice. Because otherwise, you just have individual, clearly very broken voice.
Master the use of media to increase our presence. Our presence.
And trainers.
Yeah, I don't know, but it's very strong. Their job.
How do people like Thomas feel their work is very doable, very sustainable, very easy? Yeah, that's interesting. But not easy, but it's sustainable. It's sustainable. It's a job that you can actually achieve. Yeah.
They have some class action.
reflection with all the community and the something to see more makes people act together. Always on the line.
We have strikes.
Where we are
that's a form of group action. No, but I think you just reach the first step. I think first step is just communication. Just communicate to
same voice. Yes. It's hard to make the same value because maximals were 5G, but it promised for at least many units that we share the same view.
I would say they're trying to satisfy that system.
And in different points, different directions,
show them what's the plan, what's
but it's only the
next steps,
and sometimes
maybe we'll have those behind us.
But it's the same. You were saying mentioning the groups of patients and involved in more. First, we worked like that, and still medicals and act as a center. Next, if you together as a waste of time, if we're able to do it for ourselves, then we invest that creating real patient group, really author group that will be more basic. If we're not able to federalize around the organization, organize us for other people to do the same.
How culture changes. You can't come from like the college of down there. And it feels like there are lots of local changes going on. There are no way to do them together, so everyone feels like they're doing what they can on their own and that they will never change the system. Well, actually, if you add a way to make these people talk together and realize that they want to do the same thing and that it's working, maybe it could, like, something could emerge from that fairly easily. Because it's actually already kind of happening.
Groups that are taking
Totally
place.
easily because it's already,
Always patient, and we can't see them like a big, huge yet, but present. So I think the change is because of the trend.
Yeah, but you see that there are some people over at trends that are
easily accessible for the public. That's a question. We have lots of different but the result of our discussion would be accessible for the public. That's a question. For example, UK, Twitter, Facebook, maybe YouTube, something that young people
that's culture.
And maybe that's more useful than the traditional media, Defan or something.
Interested, you're pretty young doctors. Do you really want to work on your own?
No, in my opinion, I do. I think I would say there's only
and only 4 hours.
There's no backup.
4 out of 12.
But I think the key
we want to meet one branch and don't want to work.
okay.
There's age factors. Younger doctors want to when you ask young interns and one of twos and they want to work alone, none want to work alone.
Because I think that's also the game changer. I think so you have to listen to what your young coming in GPs want to do. So we know that in the UK, most of our GPs, they don't want to be principals like I am partners. They don't want to be running an organisation. They don't want to be like risk and all that. They love the patient work. They want to do the clinical work, and they want to stay in a stake in what's going on as well. So I think it's another.
How we can increase.
But if we don't listen, I think that's 5 years. That's 20,000 doctors. If we don't listen to what the new generation of GPs want, we'll also design something that's not sustainable if it's not fit for the purpose. It also needs to be in line with roughly what the patients want and need. What they need, what they actually need. Once is good, But in a free health system, what we have, their needs is more important. What they really need.
I've been part of the same organization. Doctors, I didn't feel a membership.
But that's logical because it's a federation of organizations, so to have federating.
But we are de facto. We don't, but we are not actively members.
Implications towards the GP work.
Other ideas?
Questioners and more understand what being partner in mind. It will be good in private.
So your plan is to find a solution to make each of us members directly more
the fact is I don't have no
integrated in the
touch already my
if we can concentrate on building myself, we can strong moral force as a force of communication. With the access,
it's essential to me to
we're doing that, even we can have all the impact on the raise the funds.
Okay. When we got to feedback as well, so what are you going to feedback to?
What are you?
You're the feedbacker. You've got it. Oh, brilliant. You've got a picture. Great. As long as you've got it. As long as you've got it. You've got it. Okay, I think we're ready.
I'm not sure about my idea, but is it okay? Give it as you say, maybe to make like show that shows our activity to make us more.
I think we are only, yes, we have to make your report in 3 minutes and we have only 2 minutes to discuss. Okay? But I think it should be the start of the reflection. Yes.
And break all the stereotypes.
Thomas, you want to come to the podium? You can put this on your CV as a talk organization.
Or
But maybe you could find something together.
Don't worry, it's the chair.
And engaging.
Okay, let's draw back. And whilst Thomas is I'll find it. Who's feeding back to this group? Who's doing the feedback?
I'm the feedbacker.
Fantastic. Stand, be ready to follow on. Yeah. Come up and be on. Yeah, off you go. Let's go.
do you need to write it down?
No. Just talk. I think you're going to.
After I withdraw from we'll take
Bonjour, hello. So it was really productive. Sorry. We centered about the ideas in the question. Let's start with the youngsters that we should use and listen to more and more the expectation of the young interns in training and the young doctors who are just installed, to not forget them, especially in the construction of new politics. Could be a break otherwise. Otherwise, we also start by try to find some problem first in order to solve to create ideas. Maybe the problem is the unions in France. I won't say more because we are filmed. But we all know what is the problem. 50 or more. I don't know if I got this idea well, but it was a problem of vision. I don't know who said that, but I didn't write it well, I'm so sorry. Maybe the point of view, that was that, yeah? Who said that?
I think it was me.
Yeah.
The point of view that the difference of point of view?
Yeah.
In the different territories in France?
Yes.
And the young doctors versus the old doctors?
And between
Paris versus
yes, the countryside and England.
Yeah.
And we need to maybe stop focusing on differences between healthcare system and see what are the main arguments and come to a proposition of maybe a workshop with the Royal College to find argumentation, discussion and arguments in order to be able to convince people locally, mainly locally, and afterwards see if the propagation could be in a way of staying and leads to national openness and new project. But guidelines from the national point of view with our system at the moment, on every level, is kind of maybe the fairy tale utopia. And what we say, yes, local is good, national is good as well. And how can we use the patient more and their advice and use their knowledge as cherish their knowledge maybe. It should be better. And in France we have principally, mostly, yeah, pathological, one pathology association of patients. What is a sample for your neighborhood or a trench of age could be create? Well, can we use that? Maybe do a stage or 2-day or 3-day discover in a practice in England as a senior GP, not as a trainee necessarily, or both, in order to discover your organization and to give to galvanize our will to change and optimize our system.
Any comment from your group?
Any question?
Any comment?
No comment.
Last question.
Hi. So from our groups, we had some kind of sharing the same ideas, especially about the thing that we don't have like good communication in the country. It's kind of federating right now, and it's getting structured by the college, but it's still that we have many unions and many different groups sharing different views. That it's very difficult to gather the same voice. That's all the work of Jean-Pierre right now. Maybe we won't come to a solution right now, but what they put in is actually getting us to improve and being all together more and more, also internationally. And I think that's a good part to go about international exchanges, sharing views about how it works and and what works and is good, and show that it works, and what doesn't work is also good to know before we're getting something new. Also, we had the same views about getting patients more involved, to get with more patient-centeredness. That's the main point and trend, I think, all over the world. And getting there is actually, I think, getting all doctors with different views to the same points. And we should start there. Or maybe we should go on there, because some other people studied there before. And we should go on that.
Something or remark or quick? Not question, but only comment.
Henry for president.
Yeah.
You can vote for me.
Okay. I think, Steve, do you want to add something? I think it's important for the conclusion and for perspective for us.
Okay. Thank you. It's been fantastic being here with you and hearing this lively discussion. I think, you know, as family doctors, we should always be aspirational. We should always dream. What could be better? You actually, in France, have enormous resources. You have plenty of GPs. Numerically, you have lots of GPs. I think you have twice as many in France as we do, 100,000 patients in the UK. So you have lots of resources. How can this be best used for your patients to deliver the very best care? Often we think about the triple aim of healthcare to improve outcomes, so make patients better, to improve cost effectiveness. But the one thing, I can't remember the third one, but the fourth thing, which is very important, is to, which we call the quadruple aim, is the notion that we improve the experience of working within the system. Okay, so quite often in the UK we'll do something that's great for the patients, they really like, it's really popular, but actually it's flipping awful for the doctors or the carers or the nurses or the admin people that work within the system. And it's actually very important that we look after ourselves, and I think you as people who've got decades of work ahead of you, you need to think what's actually going to sustain you professionally, what's going to make you a better doctor. And I think working in isolation, I hope, would be one of the things that you'd be saying, I don't do that anymore. I don't want to work in isolation anymore. I do want to work closely with other medical colleagues, but not just medical colleagues, but social workers, nurses, other health professionals, because we can all learn together to work for the best patient care that we can for the money that we have. There's always going to be a finite amount of money in any budget. How can we make that work the best for the patients, but also work well for us so that we can have a sustainable, rewarding job? I say you've got to have dreams, and you've got to articulate those dreams. And I say, and what we have in the UK is not perfect by a long chalk, okay? But all I'm reporting back to you was actually we made a campaign and we got pretty much most of it. And you too can have those dreams, you too can have a campaign, you just have to get behind it. People have to decide what is it you want? How do you want to change culture? Because I can't believe that anyone in this room actually wants to largely carry on going exactly as you are now. And that's about professional power, professional buy-in. And that's why we have Royal Medical Colleges, that's why you have professional bodies for you to buy into and make change, positive change. Here endeth the session. Thank you very much, it's been a huge pleasure.